This conference will now be recorded.
So welcome all of you, and I would like also to welcome Dr. Abtihal and all of them, both of them, Dr. Fatah Rahman and Dr. Abtihal, they are on duty, but they today will be with us, inshallah. They will try as much as possible. Okay. How are you? And welcome you today to our room. And I hope all of you today will enjoy this session, and I hope it will answer all your concern and your query about MRCOG Part 2. Okay? Kindly, my voice is clear?
Yes. Okay. Thank you, Dr. Shaz. It's clear.
Yeah, that's fine. Okay? So just prepare your question, and inshallah, all of us will answer your query today. Okay? So today, our session will be on how to prepare yourself to enter this difficult exam. Okay? Sorry. MRCOG Part 2, when you reach and you pass this exam, it will be a great achievement because, you know, this Part 2 is a great achievement. And by this membership, it is not only just a matter of knowledge, but also you will improve your career, and you will see this touch on your daily work. Okay? So even in your hospital, you see that your colleague will start looking for you, and even they change, they're looking for you, and they trust you, respect you, and even your hospital will be proud of you. Really, really, it is a great achievement. And even you have a skills of how to communicate with the patient, how you deal in your daily life even. Okay? And also you will learn that you will be patient, because it is a tough because you will run through a difficult time and a difficult situation. Okay? Hello, my voice is clear?
Yes,
Hello?
clear, Dr. Yes, clear.
Hello?
Hello, Dr. Yes, clear.
Yeah. So really, really, it is a great achievement, inshallah, and all of you, inshallah, you will do it. As much of people, they run through the same difficult challenge, difficult challenge and difficult situation. So inshallah, you will do it. Okay? Our team in mastering MRCOG, me, Dr. Rasha Ahmeda, I'm working right now as a registrar in International Medical Center, IMC, Jeddah, and I gained my MRCOG membership, full membership at last December. And Dr. Fatah Rahman is an assistant prof and consultant, and in Najran Hospital, and one of the leader in Telegram groups and in teaching, and have a high quality skills in teaching and effective way of learning. Okay. Dr. Abtihal also registrar in my medical center, and also she gained her membership in full membership last December 2019. Okay. Today our agenda, the first one is we will talk about what is MRCOG Part 2 exam. Okay. Actually, MRCOG Part 2 exam is the difficult part on this long journey to reach the full membership, and the difficulty came from many different points. Okay. And if you, inshallah, will end this dream into reality, it will be a great test of achievement, as I told you, my friend, and also a lot of celebration as well when you finish this long journey. Okay. Kindly, please, just I request from all of you to mute. Sorry, I would be grateful for that. Okay. Are you hearing me? Hello?
Yes, دكتورة رشا. It is clear.
Yes?
Yes, ma'am, it's clear.
Right?
Yes.
Yeah, okay. So why, from where this difficulty came? If we ask ourselves, we know that MRCOG part 2 really is the difficult part of to gain this membership. So why, from where it is difficult? Okay, first thing, as we know that it is difficult because of the knowledge, because you are going to build up knowledge, okay, and this knowledge will go with you for the third part. And believe me, no time again to build this knowledge. As for example, it is very shameful if anyone asks you after you gain your membership and you don't know how to answer, or even if in any different cases, okay. And also, you go and you will struggle with third part if you don't have a good knowledge and you didn't build your knowledge. If nowadays we know many people and many candidates that they fail, and they ask them to repeat this part. Am I right? Okay. And so need from you to build your knowledge with this exam. And also the second cause why it's difficult, from it came from that you will upload your mind, okay. Hello? 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 Yes. And also you will upload your mind by a lot of information, okay. And of course it is very easy to read, but it is difficult to catch this and grip this, all this information in one shot or in one moment, one time, which is a exam moment, okay. So you need to know the smart way to study for that, and this will be discussed with Dr. Abtihar later, okay. The third cause why this exam is difficult is that, one thing is that nowadays in UK, the number of trainee in NHS to go to this specialty of OB/GYN, it is it become a little bit decreased, or maybe these years, the last years, it become more and more decreased. And if you read about this in the NHS, National Health Services in UK, you will find that because it is a stressful job, okay, and also especially with a demanding hospital, busy hospital, that you cannot manage between your social life and your tough rota, okay. So, and this is one of the cause that it will be really a great achievement when you train yourself, and when you become up to your knowledge, up to your challenge, and you achieve your dream, okay. Then also, so time to study will be limited. If you have, for example, a demanding busy hospital, your time to study will be limited, and by this way we need to prepare ourselves in a smart way rather than a hard working way, okay. Also, the very important things that, for example, sometimes the source of reading, most people, I think, or if the one have no experience in this type of examination, his source to have the information not updated. So you need your source to be updated, and also a lot of source of information, and you need to go through all of them, okay. You need to go through all of them, or if you have, for example, summaries or these things, I think it is better, but you should know the topic from different sources, okay. And the second thing, don't go to read from source of textbook, like textbook, okay, and it should be from UK sources as well, okay. Is it clear so far? Hello?
Yes, دكتورة رشا. Yes, it is clear.
Okay, so yeah, okay. Then after that, we'll go for the frequently asked question. about the source to study from. This is very important, very, very important. You should know where to bring this source to study. It is from Green Top Guideline. You should know how to open the Green Top Guideline and the RCOG website. You should know also the new guideline, because you need to your knowledge to be updated. So you need to every now and then you open the website and to see what is the new in the Green Top Guideline, what is the new in the NICE guideline, the talk article, the Strat OG, okay, the scientific impact paper, the MIBRAS and the BASH and FSRH, okay, for the contraception, and the consent advice. All these things you should go around each of it, okay. And what I want to tell you is that, for example, if you have a topic and you didn't found it in Green Top Guideline, go to search in the NICE. If you don't found it in the NICE, go for TOG. If it is not in the TOG, you will go for strategy, okay. It is like this as I arrange it, or in the scientific impact paper. Sometimes you can found some topics you don't in scientific impact paper, okay. So it is also important. The second thing is that also you should know about the EMQ books, because you know Dr. Tihal, she will tell about the percentage of the EMQ and scientific single best answer, okay. And you should have British book, and you should solve a lot of EMQ, because it accounts for 60% of the exam, okay. And so you should train yourself. The second thing, frequently asked, should I depend on recall? Some people can ask you like this, because nowadays, as we know, exam is a lot of recalls and a lot of questions that repeated. But just I want to tell you about the recall is that nowadays some people depend on the recall, okay. And you know, they change the way of the exam. Sure, if ask have the advantage that you will know the favorite topics, but also there is disadvantage for that, okay. So don't depend on recall alone, because nowadays sometimes you will find the exam really completely different from the question. And you know, nowadays also some questions in the recall you will find it, and until now they don't have any answer for this question, because it is from the start the one who recalls this question, sometimes he didn't give the right answer, okay, or the right recall. Also how the third one is how to read talk article. Some people ask this, how to read the talk article. Of course, we have a lot of talk articles, and it's preferable to read the 3 last year, okay. And what I want to tell you is that first go to this talk article, and you go and read the CBD at the last, which is the question by true or false. Read it and then answer this question, true or false from the talk article, and this will be the things that they want from you to know about this talk, okay. So because you have a lot of talk article, and of course not all these things will come to your mind, so you need to have a limited, concentrated, concise points, okay. And then are the questions difficult? Also, some people ask this. What is your opinion for that, guys? Hello? Is it difficult? Are the questions difficult in the exam? Or if I read, I can get it? Anyone can answer me? Hello? Okay, let's say that actually, of course, there is uh, questions that are difficult, but believe me, all the people who pass this exam, they they answer the easy one as easy things. Okay, but of course, there's a difficult question, and the difficulty for all, and it's difficult for all, and you will solve this question by understanding and by the concept of and information that you gain from your knowledge. Okay, sometimes the difficulty in the question came from where? Came sometimes the question will be very long, or the answer near each other, or there is, for example, distraction point, or there is misleading point. So we will, if you put your knowledge again and you study well, okay, it is not just a knowledge, also it also need to you for to train yourself and to do a lot of questions, EMQ question, so you will gain the technique, okay, to solve this question. Okay, so of course there's the difficult question, and it's difficult for all. It is not just for you. Others also feel these questions are difficult, but by knowledge and by training on how this question can come, you can go through this question very easily. Okay. How to catch all this huge information in one time, and this will be most likely discussed with Dr. Abtihal for the um, the smart way to reserve with this information. Okay, just 1 minute. Dr. Abtihal. Hello.
Hello, yes, Dr. Rasha.
Yes, welcome, Dr. Abtihal. Welcome.
Welcome, Dr. Rasha, and your the other attendee. Actually, I'm on duty today, but I will try to share in this introductory session. I'm Dr. Actually, just I want to represent myself. I'm Dr. Ibtihal. I'm working currently as a specialist in International Medical School, International Medical Center in Jeddah. Actually, I'm very happy to be one of this very lovely group mastering MRCOG, Dr. Rasha and Dr. Fath Rahman and me. Okay, and also I'm very happy to share our experience and to give you some tips and to guide you in your in this journey. I will speak about how to prepare yourself in smart way, okay, and how to apply for MRCOG Part 2. First of all, actually, this part of the membership is the most difficult part, and however, many or not many, few actually, they pass their exam from their first trial. So just believe in yourself and tell yourself that I can do it. I can do and I will do it. It's not impossible. Okay. And even if you didn't pass from the first attempt or even the second attempt, don't give up. Struggle until you reach your dream. And I don't like the word fail actually. Usually I call those who didn't pass their exam, I tell that whose their success is delayed only. Their success is delayed. It's a matter of time. They they will pass this exam at any point in their life. So it's not a fail, but the success is delayed. Okay. Then so believing in yourself is very tell yourself that I can do it and I will do it and you will do it. Okay. And the other thing is teamwork. Actually, teamwork is a very important is a very important factor in this part of the exam. Teamwork, you should have first partner, one special partner. You can read both of you together. Then you should join the groups. Um, make small groups from 4 to 5 person and fix time like 2 to 3 hours per day to solve questions together, to share, to discuss topics together every day. Okay, this is the second one, the teamwork. And I encourage all of you guys to join the Telegram groups. They are very important, the Telegram groups. They are doing the free sessions, free discussions. So guide them, okay? Especially the recalls. Recalls, solve the recall in a group. It's better because there is no evidence for the recall. But for the questions in the book, there is evidence. You can go for them. But for recalls group, you can take the evidence from each other, from the teamwork. Okay. Now I will talk about the tips and tricks to pass this MRCOG. As I told, it is the most difficult part in this journey. However, you can do it from the first attempt if you prepare yourself in a smart way, not in a hard way. Okay. So for the booking of the exam, it's better to book early, so you will not be surprised by the there is no seat available, all sold out or whatever. So whenever the booking is open, go and book your exam immediately. Don't postpone it for later dates. Okay. The third thing is that, as I told, select your partner. The partner is a very important factor in this journey. So the partner, there is this specific characters in the partner. You should understand him and he understand you. You enjoy to talk with him. The partner who will encourage you when you feel tired, and you will encourage him or her when he feels tired. So the partner is very important, even in part three exam. And put schedules with you and your partner, or I can say small groups. Put schedule and follow that schedule. Try to cover everything day by day. If you put today, we will finish the early pregnancy module. So finish it today as much as you can. Don't postpone it for any reason for tomorrow, unless it's top emergency. At that time, it's fine, but try to stuck to your syllabus. Okay, the in the from the beginning, 3 to 4 hours studying per day is fine. Before that, actually 6 months for preparation. From my own opinion, less than 6 months, it will not be fine. You need at least 6 months in order to prepare yourself for this exam, or even more. For the hours, studying hours per day, you need like 3 to 4 hours to read per day, and you can increase these hours as the exam approaching, or towards the beginning of the exam. You have to increase these hours. Of course, you will need a time of work, which is at least 1 month before the exam. If you manage to take 2 months or 3 months, it will be very nice. So you need the time of work before the exam, at least 1 month. Okay, and you need at the beginning at the exam approaching, you need to increase your study time for like you can study whole the day. There is no social issues. There is no anything. Postpone everything unless it is urgent. So just stuck to your study. Unless you finish this exam, go and celebrate and do your whatever you want to do. Then um, after you read the topic, if you read the infertility module, go and search every question, every EMQ, SBA related to this topic, okay, and answer it. Actually, revising questions is very important thing in this, or a very important factor towards this exam. Okay. Um, Point number 7 is to repeat, try to repeat, solve questions, repeat and repeat and repeat again. Okay. The most important one is, from my opinion, is recalls. It's like your name, the strat or G questions. You can revise them twice or 3 times before the exam. At least, guys, two times before the exam, revise strat or G questions. Okay. When you get there and upset, try to solve questions. Sometimes you will find yourself very tired from the stress work or from the family issue or whatever. Your mood is not fine. You don't want to read. At that time, you can go and revise questions. Just revise question, read question and answer them read the question with the evidence. So you will read. Automatically you will find yourself, you read something. It's better than nothing. Yani. Okay. Try always that your information to be updated, because there is many new guidelines nowadays. We have, I think, like the guideline of a new guideline for hypertension, new NICE guideline, and there is many new guidelines actually. Also, there is 2019 um, also new guidelines. I'm not, I don't remember at this time, but whenever there is updated guideline, go and read them. Okay. For the COVID, we have, I think, more than 10 versions until now. So from my opinion, the COVID, there is no specific guideline until now. So I don't think they will bring questions from this COVID guideline, but try to come with something. For the RCOG, they have 10 versions from this COVID. The point number 10, avoid wasting your time, as I said, by any social issues, unless it is very important. Always try to answer with evidence, as we said. Try to read the answer with the evidence. Okay. 6 months is enough. If no, for me, at least 6 months. Not if 6 months is enough. At least 6 months. Okay. Some they may need, if they have a hard duty and they have a heavy work, they might need even 1 year to prepare for this exam. Really, it's not an easy exam, and there is NICE guideline. You have green top guideline, many green top guidelines. You have TOGs, you have FSRH, you have many guidelines. So I think you need time. You need more and more time for the guidelines. If you read the guidelines 2 times, at least 2 times. And please just, I do advise all of you to make a note for your special note, like a summary of what you read. If you read the VTE guideline, make note and make summary for this, and try to put the important points on this note, like figures, important figures, exam questions. Just try to fix it in that note. So near the exam, you will not, you don't need to go to read whole the guidelines, and you will go only for your note, because you write this note and you believe on this note, you will revise only this note and go for exam. So near the exam, there is no more reading of guidelines, only summaries, tables, and diagrams only near the exam. Okay. For questions SBA and MQ, you will continue read them every day until the exam. Don't stop reading questions, especially recalls and strat OG questions. Okay. You should know that many candidates failed many times before. I don't like failed, this word. I will say those who are success is delayed. And the end they make their dream come true. So it is not impossible as many did. Even if you fail once or two times or three times, I know many colleagues, many of our colleagues, they go for they did this exam six, eight, and even 10 times. So don't stop and don't give up. Always avoid reading huge information and read from textbook. So at the beginning, you need to read everything, every information at the beginning. At the beginning, read. So you need to read the guidelines, all the guidelines in detail. Then after that, you can go for summary. Okay. Try to solve mock exams every now and then, and also solve the recourse with a big group. Revise statistics and oncology staging at the same day of the exam. Yeah, there is some topics, whenever you read them, you will forget them. Some topics like staging of the cancers. So you need to read them just before the exam, okay? And staging of the cancer, I think vulval condition, because they are the same also. So there is some topics, whenever you read them, whatever you read them, how many times you read them, you will forget them near the exam. So just try to read them like postpone reading them until the day before the exam. Okay, and practice thousands of MQ, as I said, questions every now and then. So as I said before, for booking for MRCOG, you have to book early when the I think the booking already ended for July 2020. They already booked their exam. Uh, for the coming January 2020 21, just when they send the email for booking, try to book on the same day or next few days. Yes, the booking exam for January open on Thursday. It will open on Saturday, 17 September 2020, and it will close at 4 p.m. on Thursday, 15 October 2020. But try not to reach this Thursday, 15 October. Okay, just book early on September. Yeah, so we'll go for the next slide. It's February 2020 already passed. So this one for the exam itself. The exams consist of two written papers, paper one and paper two. Each paper accounts for 50% of the mark of whole exam, each paper. Each paper consists of a single best answer and EMQ. The single best answer is account for 40% of the total marks. So the mark for single best answer is less, which is 40%, and the marks for EMQs is 60%, which is more. And actually, SBA is more easier than EMQ. Okay, so please, during your revision, concentrate on EMQs. Anyone knows to solve EMQ, he will or she will subsequently know how to solve the SBA, because both of them are multiple choices. For SBA, it's simple and it's only 5 choices. For EMQ, sometimes you will find 15 choices or 15 options. So it's better to prepare yourself doing EMQ. And I'm 100% sure everyone failed this exam, failed EMQ, not SBA. fail EMQ. No one will pass EMQ and fail SBA, no. So concentrate on your preparation on reading EMQs, please. So the duration of each paper, 3 hours, 180 minutes, okay? And the time management, always they will say the time management is your responsibility, but they recommend to spend like 70 minutes on SBA and recommend 100, this from RCOG recommendation. Yeah, so you have to stick on this one. And to spend 110 minutes on the EMQ. From my opinion, spend 2 hours in EMQs and 1 hour in SBA. This is my own recommendation, Dr. Itihar recommendation. Okay, so spend 1 hour in SBA and 2 hours in EMQ. Believe me, EMQ it needs more time. And also my own recommendation, guys, that in the exam you should start with EMQ. You start solving the EMQ because EMQ it needs more thinking, it needs energy, and it needs concentration. So you're coming fresh to the exam. Start with the EMQ, and it consists the most the highest mark in the exam. So start by it, and then go for SBA. SBA it will not cost you too much, okay? And the paper two also as well, it consists of its duration 3 hour 100 minutes, and the same recommendation. My recommendation is spend 1 hour in solving SBA and 2 hours in solving EMQ. Start with EMQ. Start answering EMQ, guys. Before the exam, I think
Okay.
Dr. Arash will talk about this.
Yes, yes, Dr. Abtihal, thank you. Thank you so much. And really, I know that you gave us your precious time, actually, because you are still in duty. Thank you very much, Dr. Abtihal.
Yes,
And
Dr. Arash, just the attendee, if anyone have any question, please.
yeah.
Because I will go. And I hope it will be, it's benefit for you. If no one have any question, yeah, Dr. Rasha, you can continue.
Okay. Any questions so far?
Okay.
Yes, 3 hours. Yes. Yes, 3 hours. They ask you, Dr. Abtihal, in the chat. 3 hours for one paper. Dr. Abtihal?
Hello?
I think she's... Yes, Dr.
Hello?
Abtihal, they ask you in the chat, is it 3 hours
Yes,
for
yes.
one paper?
The exam is 3 hours per paper, per one paper. So the total is 6 hours, and there is times in between two papers. I'm not remember. It's not up to my knowledge right now how much exactly, but there is time between the two papers. Resting time, Dr. Naima. Most welcome, Dr. Naima. Okay, Doctor. The resting hour, the resting time is 1 hour between the each paper. So the total time is 7 hours. By the way,
Yes.
you need to stop. Okay, Dr. Rasha, you can continue.
Yes. Okay. So I think there is one asked me in the chat about just 1 minute. Asked me, I think Dr. Fatima from UK. She asked about the time. Dr. Fatima, now the time is 2:53, almost go for 3 p.m. KSA. Okay, Dr. Fatima, because you are before you ask about the time. Okay, so let's go for before the exam, what we will do before the exam, and then at the date of the exam. Okay, and then about our course. Okay, so before the exam you should read the green top guideline, the NICE guideline, the oncology, the contraception and sexual health, the talk article, and the strategy also at least 2 times. Okay, and the strategy very important because you know it is some question it came from strategy, and even the way and the language of the exam, it is like the strategy question. So it is very important to read and to solve the EMQ that came from strategy. Very important actually, especially for the antenatal, labor, antepartum hemorrhage, all these things, it came from the strategy. Okay, and then also you should solve, as Dr. Abtihal taught us the smart way. You should solve questions, the EMQ question every day for 2 hours at the beginning, then increase the time near the exam. Recall at least 3 times, including 1 month before exam, and in the last week of exam, 3 hours daily. This is very important because you know sometimes the Royal College, we don't know about them. They can nowadays they try to change their way, not to bring recall question, but they can bring recall question. Okay, so better to arrange yourself, and you have something in your hand, better to do it and modify it and read it carefully. Okay, and then you will you have it, so it will be easy and you will have a high mark after that. So you have things in your hand, better to do it, because some people said that it is not they change the way, but there is no guarantee that they will not bring recall next time. Okay, then at the date of the exam you should know that by now you are loaded with knowledge, more than enough actually to pass this written exam, but only if you keep calm, contain, vigilant also the exam, and the unnecessary fear and perplexity will evaporate all that knowledge. All things will fly away from you. Okay, so better to concentrate, keep calm, whatever will happen. I think all of you have worked hard and get a lot of knowledge, so in all the cases you are a big winner. Okay, the first step to score high is by following this advice. Read the question well again and again. Read the question well again and again. This is very important and first step. Okay, then start with the EMQ question first, then the single best answer after that, before answering any single best answer or EMQ, and understand the heading line well. Actually, at that time when you are reading the question, no time even to write, so better to have like a mark or like underline the important point in the question. Okay, and you should think and answer according to guideline and the UK practice, because you know some people they said that I read a lot and I do all my best, and but the problem when you go through them, sorry please kindly just if you are you to mute yourself please. Yes, hello. So as I thought that you should think and answer according to guideline and UK practice. As you know, the most important thing is that to stick to their guidelines. They didn't want from you any information from outside. They want their guideline, UK practice. Okay, this is very important. Read all items of the EMQ well and again and again. Okay, before answering the EMQ, to avoid repeating yourself and waste important space and time, and underline or highlight the keyword. This is very important. Be systematic and comprehensive in your answer. Make sure to sleep early the night before the exam. Go to the exam early. Be in your chair early. Okay? Every EMQ no more than 3 to 4 minutes. If not finished, still move to the next and try to answer it, because maybe no time and the answer you doubt on it maybe is the right answer. So just try to mark it for revision. Okay. Then make sure your candidate number written correctly in your all paper. Remember that you will obtain the mark if incorrect place. Don't repeat yourself. Very professional. Remember, you, the senior registrar and the examiner, want your management. Means that don't go beyond your level, okay? Because the examiner, he didn't want from you to be a consultant. He will examine you and see what is your level. He didn't want, for example, to do to think beyond your level, okay? And also, I advise not to go through the strange topics and you try to clear it or to try to understand it very well, okay? Because sometimes difficult topics, it is not your level. It is for the subspecialty, okay? So just know the main important thing that the examiner wants from you. So each topic, better to read it and know what is the what came in the question, and then after that you answer according to that. But don't go beyond your level. Be systematic in answering question. Avoid jumping from one to another. Avoid you displacing the answer, particularly in the single best answer and EMQ paper. This is a fatal mistake actually. And put an answer even not sure to keep the place and highlight in the question sheet to return it at the end. Okay. Make sure you have the answer in the right place. This is very important. That the answer for question 1 or for question 18, it is the same the answer for question in the answer paper. Okay, this is very important. Take light snack in between exam parts and avoid drinking a lot of fluid, as you know. Make sure now your bag ready with your ID. This is the date of the exam or the day before the exam. 2 pens, enter slip, sharpener, ruler, pencil, eraser will be provided, but take extras, okay? Avoid tight clothes or uncomfortable shoes. Take paracetamol for just in case. Visit the washroom just before the exam. Don't drink any energy soft drinks. Try this because this will cause confusion, diuretics. Okay. Don't be panic. If you see unfamiliar question and write safe point, even if you know nothing about the question. Okay. Travel to the venue the day before the exam to see where is the area. This is very important. For the statistic, oncology staging and management plus chart, revision is must at the last date. And statistic oncology staging must be on the day of the exam, early morning. Okay. Be strong fighter till the last question. You deserve the pass. As soon as possible, take a piece of paper and write down the question you could remember, even the stem for the help of others. This is very important. Okay. Any questions so far? Hello. And also, I want to tell that you should have at least 3 weeks, for example, day off work, because you need your mind to be a little bit not busy. Okay. How to solve the EMQ question? This is very important because you will gain 60% mark. So read the scenario well, know what he wants from you exactly, then underline the important point in the question as no time to write it, okay? Especially if it's a long question. Put the answer in your mind, then search for your answer. And while you are searching, read all the options, okay? As maybe there is a better, more concise answer. This is very important, actually, okay? And finally, don't neglect yourself or your family. Really, because all these things, you do it for your family support and all these things. You don't neglect this. Also, it is my good opportunity to congratulate for all who passed in our free groups in Telegrams. Okay, last February, all these from Dr. Faith's Telegrams groups. Okay, and also secrets group, and on our free group actually. And I from here, so I will tell them congratulations for all of them, and inshallah they will clear their part 3 soon, inshallah. Okay, about mastering MRCOG part 2. Dr. Abtihal, you have anything? Hello? Dr. Abtihal? Hello? 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 Okay, so about mastering MRCOG part 2 course, actually we have a vision and mission. Our vision is that to work closely with our students and to provide excellent teaching and support beyond the scope of our course, and bring your dream into reality. Okay, I think one of our candidates in the last batch is here. Any one of them is here? Hello?
Yes, Dr. Rasha. Yes, Dr. Rasha. If any of our previous batch here just can share with us their experience. Dr. Najwa, Dr. Ghada, are you there?
Yes. Hello. Assalamu alaikum. How are you, Dr. Abtihal?
How are you, Ghada?
Yeah,
How are you?
I'm fine. I'm fine.
Happy
Thank
to see you
you.
here.
Yeah, I would like to thank you, Dr. Abtihal and Dr. Rasha, for simplifying the topics. Really, what was difficult and long guidelines like intrapartum contraception. It was very, very difficult even to finish the guideline itself. We solved a lot of problems, a lot of questions, analyzing questions so we can think clearly in exams. So really, it was sharing the struggling with the group.
Thank you so much.
Oh, thank you. Jazakumullah khair, wallahi, wa inshallah. يعني
You are welcome.
our successful into you have a role in our successful in this exam, inshallah. Jazakumullah khair.
If you are one of our best candidates, and I believe you will pass this exam, inshallah.
Inshallah, Dr.
Yes,
Abtihal,
exactly.
pray for us.
Yeah, inshallah.
Anyone
Thank you, Dr. Ghada. Really. Yes, you have a good knowledge, actually, Ghada. Really, you will do it, inshallah.
Yeah, thank you, Dr. Rasha. But really, thank you for your support, wallahi. Sometimes, Dr. Rasha was calling us to attend the lecture. Sometimes we get depressed because really you feel difficult to continue or to carry on in this path. But thank you for all the group.
Yeah, thank you, Dr. Ghada. Actually, Dr. Ghada, this exam needs help, and you cannot go in this road alone. You should have a help from us, from even your colleague, your study partner. Really, this exam of help, and inshallah, we will do our best, inshallah, to bring your dream into reality. Thank you,
Inshallah,
Dr.
thank you. Excuse me, I
Yeah,
have to leave. I have duty. Thank you.
Dr. Ghada.
Okay.
We appreciate your feedback. Can we hear more feedback from other candidates, please?
Yes, Dr. Abtihal, me.
Yeah, Dr. Najwa, how are you?
Alhamdulillah, fine, Doctora. How are you, Dr. Rasha, Dr. Fatah Rahman? How are you all? Inshallah, everyone is
How are
fine.
you, Dr. Najwa? How are you? Yeah. Thank you so much, Dr.
Dr.
Najwa.
Rasha. Yes, thank you. Welcome, Dr. Rasha. I would like to thanks really you and Dr. Attihal, Dr. Fathar Rahman for the good effort for us. I'm the one of the candidate attend this course, Mastering Part 2 course. Really, I get benefit. You help me. You simplified the guidelines for me and also for the others, inshallah. It make it simple. You help us how to read, how to answer questions. You encourage us to go far to get success easily. Thank you so much, really. I don't know how to thank you. I thank very much.
You
I
are
hope all
welcome,
the
Dr. Najwa.
members.
Actually, Dr. Najwa, we are believe that you passed because you get just, I think, 61 or 62 from the past last
To you,
batch. Yeah,
yeah,
so I
the six,
believe you are passed.
yeah,
You passed. Yeah, inshallah, you will do it.
inshallah.
Inshallah. Yeah, you are. Yeah, one of our best candidate actually, Dr. Najwa.
Yeah, yeah.
Thank you so
Thank
much.
you,
Thank
Dr.
you so much.
for your feedback. We are very happy
Thank
to see you here in this meeting. Thank you, Dr. Najwa.
you. Thank you for you. Thank you. Allah
And hope you
يوفقكم إن
all the
شاء الله.
inshallah.
إن شاء الله.
Thank you. So just a brief about mastering MRCOG, and then we will have our free topic today, which is laparoscopy in pregnancy, the new guideline, which is 2019, and we will discuss it now. Okay. So just brief about our course, mastering MRCOG. It is as we said, our mission also is to pioneer a unique approach of teaching, and our course is proven to be valuable for MRCOG and MRCBI. And we will provide you with all the topic summaries and even the record and all these things, okay? Because nowadays we are working on our website. Inshallah, it will be ready of 1st of June of July, inshallah. And it will be a very informative session, and we will clarify all the points throughout our syllabus. We will train you to know how to even summarize for yourself, okay? And also we will provide you with a material, and no need to go beyond it, okay? This it will be new for this batch, okay? And also it is summary from different sources, so that just the topic will be covered from different sources. And also you will learn how to utilize your time, and to how to proper management your time, and how to do your own schedule, and to not to waste time, okay? And also we'll put a schedule for you, and we will observe how you will restrict and how you will get benefit from this, because we will observe you. Each month will be, there is a mock exam, so we will know if you follow us. And even we did a lot of topics actually, and all topics in the previous batch was each topic we have a question on it, EMQ. I think they can tell about this, Dr. Abtihal and Dr. Our batch. I don't know, maybe. Okay, so for example, there is each topic we have a question on it, so that you will fix the information by that. Okay, not just a topic and go. We will discuss the topic, and we will put a question, and most likely it is EMQ, okay, from different sourcing, strategy, recall, and all these things, and then to fix your point. Okay, any question? Hello? 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 Are you hearing me?
Yes, Dr. Rasha.
Yes, okay. So today we will talk about laparoscopy in pregnancy, which is a joint, actually it is a joint guideline between the Royal College, okay, and the British Society for Gynecological Endoscopy. And this is new one, which is 2019, okay, new one. So laparoscopy is widely utilized to diagnose and treat acute and chronic gynecological and general surgical condition, and it has only been in recent years that laparoscopy has become an acceptable surgical alternative to open surgery in pregnancy. Okay, this is very important. Then what is the incidence of non-obstetrical emergency in pregnancy? The incidence of acute non-obstetrical abdominal surgical emergency in pregnancy is low. Anyone know how much is it? Hello? What is the incidence of the non-obstetrical abdominal surgery during pregnancy? Anyone know? Actually, it is rare, okay? And it is occur in about 1 in 2 per 1,000 pregnancy. This is from the guideline. Clinicians should be aware of the possibility of appendicitis in pregnancy, but its incidence is lower than in the non-pregnant state. Okay, the appendicitis actually it is one of the most common surgical operation or surgical problem in pregnancy. It has a talk actually. Anyone know what is the incidence of it in developed countries? The incidence of appendicitis in pregnancy. This is very important incident. Hello. 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 Are with me? You are with me?
I hear you, Doctora.
So what is the incidence of appendicitis in pregnancy? Anyone know this? Yes, Fatima, what is it? How much? Okay, it is actually 1 in 800 of pregnancy. The incidence of appendicitis in pregnancy in developed countries. This is very important incidence, and it comes in the talk article of appendicitis in pregnancy. Okay, very important. And also, hormonal change may increase the ultrasound scan finding of gallstone and sludge in pregnancy. However, the risk of gallbladder disease appears to be reduced with pregnancy. The absolute number of torted and hemorrhagic ovarian cysts are low in pregnancy. Fertility treatment with GnRH analog involving control ovarian stimulation appear to increase this risk. Okay, so the GnRH analog, it will increase the risk of ovarian hyperstimulation, okay, and then the problem with ovarian cyst will increase with this problem. The reported incidence of ovarian cyst in pregnancy varies between study, depending upon the study population. The inclusion criteria and the size of the ovarian cyst, okay, if a cutoff of more than 3 centimeters is used, the incidence will be 1.2%, and this is very important figure. Okay. Actually, this is very important figure. If a cutoff more than 3, it will be, the answer will be 1.2. Okay. If a cutoff is more than 5 centimeters is used, the incidence will be 0.05%. In non-pregnant women of reproductive age, the incidence is 1.8%. If the cutoff is more than 4 centimeters is used. Okay, all of them are very important. So if the cutoff more than 3, the incidence in pregnancy will be 1.2. If more than 5, incidence in pregnancy is 0.05. If non-pregnant, the incidence will be 1.8 if the cutoff is more than 4 centimeters is used. This is from the guideline, okay? Ovarian torsion in pregnancy is rare in absolute term, and in other series, torsion, subacute torsion or hemorrhage, necessitating a surgical intervention occurred in 1 per 4,000 pregnancy. One of the study reported a torsion of rate of 1 to 70,000 with hospital admission for pain required in 16% of women with cysts. The incidence of ovarian torsion in non-pregnant women is not known. Okay, so this slide actually the most important is that the figure of the ovarian cyst, okay, the incidence of pregnancy is according to the cutoff. Okay, this is very important. Then what are the specific concerns of ovarian cyst accident, appendicitis, and cholecystitis in pregnancy? one of the questions of the guideline, okay? Without appropriate surgical treatment, appendicitis and cholecystitis carry specific risk in pregnancy, including generalized peritonitis and maternal sepsis, resulting in miscarriage, preterm delivery, and stillbirth. And this is very, very important. What are the risks of this specific concern, like appendicitis, like cholecystitis, like ovarian cyst accident, is that it can result in generalized peritonitis and maternal sepsis, including which will result in preterm delivery and stillbirth. This is very important. So it can come to you in SBA or even it can come to you in EMQ. Okay? My voice is clear? Hello? Any questions so far?
No, not yet.
What is the safety of laparoscopy? Is laparoscopy in pregnancy safe for mother and fetus? This is important question. Okay. So, in comparison with open surgery, laparoscopy for adnexal. Kindly, can you mute yourself? Yes. So, in comparison with laparoscopy for adnexal and gallbladder disease, has no increased risk for mother and fetus. Appropriate surgical equipment and expertise is available. Laparoscopy should be considered an appropriate surgical approach. Okay, this is very important. And so laparoscopy should be considered as appropriate surgical approach wherever appropriate surgical equipment and expertise is available. There is no additional risk of fetal malformation or stillbirth in women who undergo non-obstetrical surgery compared with pregnant women who do not undergo surgery. This is very important. And this also came in the SBA. So no risk of fetal malformation or stillbirth in women who undergo non-obstetric surgery compared with the pregnant women who do not undergo surgery, okay? The maternal condition necessitating surgery may be associated with risk of miscarriage and preterm labor. If we go to surgery, there is a risk maybe of miscarriage and preterm labor, but fetal malformation, no additional risk. Okay? Only experienced laparoscopists should carry out this procedure, and outcome should be carefully monitored. So if surgery will be done, it should be done by only by experienced laparoscopists. Okay? Joint surgery between gynecologist and surgeon is encouraged, and the decision between laparoscopic and open route of surgery should be based upon the available expertise, infrastructure, background history, gestation, and the woman preference. What are the maternal benefits to laparoscopic compared to open surgery? Laparoscopic surgery, as we know, the laparoscope even always have associated, the advantage of it is faster recovery, shorter hospital stay, and a trained to lower rate of wound infection for pregnant women. What are the maternal risks from laparoscopy in pregnancy? What are the maternal risks? Okay, general laparoscopic surgical risks such as hemorrhage, herniation at the port site also apply to laparoscopy during pregnancy. Due to the enlargement of the uterus and subsequent limitation to the visual field and surgical access, there is an increased risk of vascular and organ trauma, in particular uterine perforation, although this risk has not been quantified. Clinicians should counsel women about the consequence of uterine perforation, which include subsequent uterine rupture, infection, preterm delivery, laceration of the fetus or the placenta. The size of perforation is likely to be of importance. So when you put a plan that you will do a laparoscopy in a pregnant woman, you should tell her and counsel her regarding this risk There may be a risk of uterine perforation, which include uterine rupture, infection, preterm labor, laceration of the fetus or the placenta. All these things you should tell the woman about it. Clinicians should be aware that there is increased risk of bleeding due to increased vascularity of the uterus and the nexa, but this risk is currently not quantified. Okay, are you with me? Hello? I feel that you are sleeping. Just I want to encourage you to be fresh. Okay, I will ask you one of the questions that came always in the recall. What is the risk of adhesion? Because this is in laparoscopy, always came. What is the risk of adhesion in midline incision for a woman with laparotomy, for example? Anyone can tell me?
35 to 50%.
Yes, and about that, excellent.
55%.
Yeah, excellent. And about the transverse incision, how much?
40%.
23%.
23%, excellent. Okay, so can just I have a question. What is the percentage of unrecognized, for example, bowel injury during laparoscopy? Anyone can know what's the percentage for that? Also of the important
30%.
question. How much?
30%.
30%.
30%.
The bowel to be recognized, it is 30?
0.6 were
I
1000.
recognize is 30. Incident recognizes 60%.
I think 80 to 85%, as I remember. The bowel, because before we revise it as it is from big to small. So unrecognized for the recognized for the bowel, it is 80 or 85%, and for the bladder, okay, it is I think 50. Half of it will be recognized and half of it will be unrecognized during surgery, during laparoscopy. Okay, and for the anyone tell me about the ureter? Hello? Hello? Are you hearing me?
1 to 2%.
For the ureter to be hello?
1 to 2%.
For the ureter to be recognized, how much? This is very important actually figure. You should know it. Okay, so from the talk article, for the ureteric to be recognized, it is only a third of ureteric injury are recognized. Okay, so as I tell you, we will go from more and more. So for the ureter to be recognized is third. For the bladder, how much? As I told you before. Hello? Hello? For the bladder is half, 50 to 50. Okay? And for the bowel is the biggest. It is 80 to 85 to be recognized. Okay? Is it clear?
Yeah.
Okay. So, yeah, what are the maternal anesthetic risk of laparoscopy? Actually, I asked because this is very important in the MRCOG Part 2 exam. Really, really important, this question, okay? What are the maternal anesthetic risk of laparoscopy in pregnancy and how can these specific risk be safely managed, okay? The preoperative anesthesia review should include relevant features related to the pregnancy, such as gestation and pregnancy-related comorbidity, as well as the routine anesthesia history and examination. So you should, before you start, you should have to take a history to see if there is any comorbidity in this patient, if she did before previous surgery or whatever what she had. Okay, there should be early involvement of an obstetric anesthetist or at very least consultation with an obstetric anesthetist. Okay, aspiration prophylaxis should be administered and strategy for airway management should be made. General anesthesia and endotracheal intubation are essential, and the use of laryngeal mask airway is not recommended. This is very important. So general anesthesia, endotracheal intubation are essential, and the use of the laryngeal mask airway is not recommended. This point, actually, it can come in EMQ or in SBA. So take care. Okay. Creation of the pneumoperitoneum should be gradual, as should alteration in maternal positioning. Pregnant women undergoing non-obstetric surgery at an added risk for venous thromboembolism, and the risk for venous thromboembolism should be stratified and prophylaxis considered as per the Royal College of Obstetricians and Gynecologists variant of guideline. What are the fetal risk? Now we know the maternal risk. What about the fetal risk associated with the anesthesia? And what strategy can be employed to increase the safety for the fetus when pregnant women require non-obstetric laparoscopic surgery? Okay, so modern anesthetic agent, muscle relaxant, and opioid are not thought to be teratogenic when used in therapeutic clinical doses and when the maternal physiology is maintained. Clinicians should ensure that the uteroplacental blood flow is maintained by avoiding maternal hypotension. Maternal arterial CO2 should be controlled, avoiding hypo and hypercapnia, which means that increase the CO2 or decrease to maintain optimal uteroplacental flow and thus avoid fetal acidosis. End-tidal CO2 can be used as a surrogate marker for arterial CO2. Okay. Okay, so who should be involved in the management of pregnant women requiring laparoscopy for abdominal non-obstetric condition? Actually, of course, it will be an MDT team, means that a group of doctors, and should be a charge of the care of share the charge of the care of this pregnant woman requiring laparoscopy. Depending on the individual case, this team may include gynecologists, who are the doctors. They are the gynecologists, the general surgeon, anesthetist, obstetrician, and neonatologist. Okay. Laparoscopic surgery in pregnancy should be performed by advanced laparoscopic surgeon with appropriate training and competencies in order to reduce complication and operating time. Okay. Anyone can tell me about hello?
Hello?
Yes. Are you hearing me?
Yes.
Yeah. Okay. So pregnancy should not be a reason to delay urgent surgery. If the expertise to undertake laparoscopic approach in pregnancy is lacking, then the open route is acceptable. And since maternal and fetal outcome are good, both laparoscopic and open route are acceptable depending on circumstances, since maternal and fetal outcome are equally acceptable. So for both, the maternal and fetal outcome are equally acceptable. Okay? This is also important. At what gestation should laparoscopic surgery in pregnancy be performed? Okay, so when deciding on the route of the surgery, clinicians should be aware that recent small series have shown that the good maternal and fetal outcome for laparoscopic appendectomy, cholecystectomy, and adnexal surgery up to 34 weeks gestation. This is very important. Okay. So up to 34 weeks gestation, which extend historical recommendation to limit the laparoscopic to the second trimester. Okay. Any surgery in pregnancy is associated with maternal and fetal risk, and non-urgent surgery should be postponed until after pregnancy. So non-mandatory surgery, better to postpone it until after pregnancy. And any surgery in pregnancy, it will have a maternal and fetal risk. Okay. What the type of the anesthesia should be used? In most cases, general anesthesia should be employed, as we know. And where should a laparoscopic surgery in pregnancy be performed? It should be carried in a setting where adequate time, laparoscopic expertise, and monitoring facilities are available. After the age of the fetal surgery, fetal viability pregnant woman undergoing laparoscopic surgery should be treated in a unit with adequate obstetric and neonatal facilities in case the immediate delivery of the baby is indicated. This is very important also. Okay. What about the intraoperative consideration? So a clinician would be aware that intrauterine manipulation is contraindicated in pregnancy, and hence collaboration with the anesthetic team regarding positioning and tilting and experienced operating assistant is required. What intervention are needed when planning laparoscopic surgery in pregnancy? Fetal heart Doppler ultrasound monitoring may be done before and after surgery, and as we do in our routine, to confirm that fetal well-being and reassure the woman as well. So there is no need for routine intraoperative monitoring, just before and after. If there is a risk of preterm delivery, antenatal corticosteroid for fetal lung maturation and magnesium sulfate for fetal neuroprotection should be administered dependent upon the gestation of the fetus. This is very important also. Okay. Anti-D is not deemed necessary according to the guideline, since laparoscopic surgery is not included in the list of potentially sensitizing event. So no need for anti-D. Routine tocolysis for women undergoing laparoscopic or open surgery in pregnancy is not recommended because it has not been shown to improve outcome. Caution need to be exercised in steroid administration in maternal sepsis. You should have to avoid this. Okay. Where should the primary port be placed in pregnancy? Okay. Anyone can tell me in general when the primary port to be placed in the gynec surgery? Hello?
In the umbilical area through the intra-umbilical incision or sub-umbilical incision.
Yeah, excellent, Doctora. So, and what about the pressure before the operation?
12 to 15.
How much?
12 to 15.
This is during the procedure, but before?
25.
Before the procedure, intra-abdominal pressure is increased up to 25 millimeter mercury.
Yeah, 25.
And
okay.
Yes, yeah. But in the pregnancy, the pressure should not exceed 15 millimeter mercury.
Yeah, so the location of the primary port will depend on the level of the uterine fundus. This is for the primary port. Now here we will talk about the insertion of it in pregnant woman so that we have a uterus, we have a uterine fundus, okay? So the location will depend on the level of the uterine fundus, and the uterine size should be determined by palpation or ultrasound. In the absence of randomized controlled trials, clinicians should choose their primary port location, including umbilical, supra-umbilical, subxiphoid, and palmar points, left upper quadrant in the mid-clavicular line, as we know, according to the uterine size. Okay, so these are all the area. So you should revise it: umbilical, supra-umbilical, subxiphoid, and palmar point, according to uterine size, location of the pathology, and operator experience. It's very important, this area, okay? It has been suggested that in late second and third trimester, primary port site could include 1 to 2 cm below coastal margin in the left palmar's point or right mid-clavicular line, or 3 to 6 centimeters above the umbilicus in this midline. Okay? So in the late second and the third, the primary side, it could include this area. 1 to 2 below costal margin in the left palmar point, or right mid-clavicular line, or 3 to 6 centimeters above the umbilicus. Insertion of an orogastric tube for gastric decompression may be helpful when palmar's point is used for access. Very important. Okay? Should the Verras or Hassoun technique be used for primary port placement? Before we discuss this, anyone can tell me what is the benefit of the Hassoun technique?
Avoid direct vision.
Are you sleeping?
Direct vision
No.
for the direct vision for entering and avoiding of injury.
Can apply Hassan techniques can apply injury to the abdominal viscera and major blood vessel, but the drawback in Hassan technique in our daily practice is it can we made a large hole through which gases leaking and difficult to increase the intra-abdominal pressure to the operating level. That's the
very important point.
So,
there is very important point. There is very important point that Hassoun technique written, the benefit of it, or the advantage of it, that it will vascular injury. Am I right?
Yes.
The first
it can apply vascular
the vascular injury, and it will decrease even the bowel injury. Am I right?
Yes.
Right?
Yes.
Yeah. Also the direct vision. And the direct vision. Okay, so this is very important for the Hassoun technique. Here we will talk to is there any okay, so the Hassoun technique reported inside should be okay, technique or Hassoun, there is a possibility of uterine injury. The benefit of Hassoun technique may include including the risk of uterine trauma and spillage of content of the ovarian cyst. This is for the pregnant lady. Okay, so clinician should be aware that in experienced hands, direct gasless entry may be an alternative, but there is insufficient information in late pregnancy to suggest that this is a routine approach, although there is no study randomized. Okay, so means that clinician should be aware that in experienced hand, direct entry may be alternative. Means that direct entry. Okay, means has to means open, but there is insufficient information for this in late pregnancy. So that now by this we will go with the conclusion that there is no one more benefit than the other. Okay, because there is no study randomized. If they ask you in the question, for example, to use Hassoun or Verras, there is no one better than the other. But in case there is experienced hand, the direct gasless entry may be an alternative. Okay, this is very important point. Where should secondary port be placed? Secondary port placement will be dictated by uterine size, pathology, and operative approach. pre-surgical planning is paramount due to the challenge of accessing the pathology given the limited degree of freedom in laparoscopic surgery and the added obstacle of the size of the pregnant uterus. Ipsilateral port placement may circumvent this obstacle. Okay, so means that the secondary port will depend on the uterine size, pathology, and operative approach. That's it. And there is no, sometimes they can use ipsilateral port, okay, if there is any obstacle. Okay. What insufflation pressure and operative pressure should be used in laparoscopic surgery in pregnancy, as we know, and as you mentioned, an intra-abdominal pressure of 20 to 25 millimeters should be used for gas insufflation before inserting the primary trocar, and clinicians should be aware that current evidence support operating pressure of 12 millimeters. What retrieval technique should be used to remove surgical specimen during laparoscopic surgery in pregnancy? Okay, here the choice of extraction method for surgical specimen during laparoscopic surgery, okay, in pregnancy should be in accordance with the preference of the operating surgeon. Okay, so means that when I want to remove this cyst, how I will take it from this abdomen, okay? If you have this, he said here that it will be according to the operating surgeon expertise, or it is what if he did this operation before or not, okay, and the preference of him. So infected and potentially dangerous specimen should be contained in a tissue bag. You will inside with the laparoscopy, you will insert the tissue bag, you will open it inside, you put the this infected material, okay, specimen, and then you will take it out, as we did in our usual day. Okay. What energy modalities should be used during laparoscopic surgery in pregnancy? Ultrasound, bipolar, and monopolar energy sources are safe to use during laparoscopy in pregnancy, and the operating surgeon should choose energy modulating based on his or her own preference. The surgeon should be mindful of principle of safe electrosurgery in laparoscopy. What wound closure technique are recommended in pregnancy? The risk of hernia formation is 1 to 2% in incision greater than 10 millimeter. Okay, can anyone tell me about the closure in the, for example, if it is in the midline or beside, when to close the fascia or the rectus, I mean, in laparoscopy surgery?
In the midline port, if the size is more than 10 millimeter, it needs to be closed.
Yes, exactly. Excellent. Yes. And if it is beside, it will be not in the midline, it will be more than
7.
Yes, excellent, Dr. Sana. Okay, so the risk of hernia, this is very important, that it is 1 to 2% in incision greater than 10 millimeter. Therefore, the fascia should be closed. Okay, should an abdominal drain be inserted preoperatively on completion of laparoscopic procedure in pregnancy? This is another question. So the operating surgeon should decide whether it is necessary to use a drain based on their preference and assessment of the individual. Okay, means that it is according to the situation at that time. Just let this azan. So what maternal care and fetal monitoring should be offered post-operatively? As we know, antibiotics should be used if there is an infective process. The choice of antibiotics should be based upon local antimicrobial guidance and drug safety in pregnancy. In the case of elective surgery for adnexal masses, antibiotic would not be routinely required. So for elective, no routine for antibiotic. Good analgesia, adequate rehydration to maintain volemia and measure to prevent post-operative nausea and vomiting should be integrated into maternal operative care. Is there a role for expectant management of appendicitis in pregnancy? Suspected appendicitis in pregnancy, timely surgical intervention is preferably may be associated with adverse maternal and fetal risk, okay? Like septicemia, like whatever. It will be very, very maternal, even to maternal collapse. Should the laparoscopic approach be prepared to me in pregnancy? Output regarding of laparoscopic appendectomy scan. Fact is needed and casualty. In view of this, it is not possible to recommend one approach over the other, and laparoscopist procedure and outcome should be monitored. So no one is better than the other. Okay? Is there a role for expectant management of cholecystitis in pregnancy? A conservative approach to gallbladder disease, symptomatic gallstone, and acute cholecystitis in pregnancy is associated with higher maternal morbidity than surgery. Clinicians should be vigilant about complication of gallbladder disease, such as gallstone, pancreatitis, since this may be associated with high risk of fetal mortality. Okay, so the clinician should be vigilant about the complication. In pregnant women with biliary colic, supportive care will lead to resolution of symptoms in most cases. Complicated gallstone disease require a more proactive approach. Okay, and the search identifies that should the I think this is just no, this is another point, but it's not important. Okay, still more proactive approach. Okay, this is very important. And then he asked about should the laparoscopic approach to cholecystectomy be preferred over laparotomy in pregnancy for the cholecystectomy? Okay, so laparoscopic cholecystectomy appears to be associated with better composite or complication, better, I mean better outcome, maternal or fetal outcome than the open approach. Fewer surgical complication and shorter hospital stay. So the laparoscopic is better for the maternal and fetal outcome than the laparotomy approach, okay? And there will be fewer surgical complication and shorter hospital stay. Should surgery for ovarian cysts be preferred over the conservative approach in pregnancy? Okay. Women with asymptomatic simple cyst may be managed conservatively in pregnancy, provided that symptoms are absent or acceptable to the woman. So if you have a simple cyst, asymptomatic, the management it will be conservatively. If the woman have a large, non-torted, but symptomatic, wish to avoid and you wish who wish to avoid surgery, okay, may be offered aspiration under ultrasound guidance during pregnancy with a definitive cystectomy after delivery if required. Okay, so if simple cyst, conservatively. If there is a large, non-torted and symptomatic, you will go to you want to avoid surgery for this lady, or for example she refused to do a surgery, at that time you can go for aspiration. Okay, and because the risk of aspiration, as we know, the recurrence will be high, so definitively after the delivery you will go for cystectomy. Okay, the risk of torsion of ovarian cyst requiring emergency surgery in pregnancy is low, and in most cases surgery may be delayed until the woman becomes symptomatic with good fetal outcome. So most likely, if the patient, if you have a ovarian cyst, most likely the risk is a little bit low with pregnancy. A systematic search identify a retrospective series that observe the rate of the torsion. There is, but it is a little bit low. Should the laparoscopic approach to ovarian cyst be preferred over the open? When surgery is indicated, laparoscopic cystectomy with pregnancy is associated with a better maternal outcome than laparotomy in the second trimester, with similarly good fetal outcome, meaning that if you have a patient in the second trimester and you will go to have an ovarian cystectomy, okay, better to go for laparoscopic one because it will have a better outcome, maternal and fetal. Good maternal and fetal outcome have also been reported for laparoscopic surgery for the first and third, okay? However, the number is small for the first and third, and this is tricky point actually. So you need to read the guideline well to know what is it. So for the first and third, it is better, but the number of reported cases is small, but absolutely for the second trimester is a good one. More research is needed to prove the superiority of one approach over the other outside the second trimester, and in the interim, choice of approach should be decided based on local circumstances and expertise. Okay? Cyst aspiration with or without concurrent cystectomy may be a safe alternative. So in conclusion, there is a mounting evidence that appendicitis, gallbladder disease, and symptomatic adnexal cyst can be safely managed laparoscopically in pregnancy. This is very important, and this is the conclusion. And most evidence is from specialist center. Only adequately trained laparoscopists should carry out these procedures, and adequate pre-operative preparation are paramount. The second thing is that, especially outside the second trimester, most included papers are from small case series, and more high-grade evidence is needed because it is difficult to perform randomized control trial for those conditions, and creation and analysis of the national large database appear to be a way forward. And this is not important for you. Okay? Actually, we end and best wishes for all of you and good luck for all of you. And you have any question? Hello?
No question, but I would like to thank you. Yes, I would like to thank you for clearing of the pregnancy and laparoscopic surgery. Thank you very much.
Yes, actually, I chose this guideline because it is a new one, and 2019 actually, and really all of us, we based on the old one. So this is new guideline, and it's a joint guideline, very important, and it came a lot of it in the exam. So it is very important as well. Okay? Any questions so far? Hello? Okay, thank you.
Yes,
And I hope all of you, you will finish this dilemma, and you will achieve your dream, and you end with this long journey, because really, if you finish it, you will become relieved, because a lot of things in your chest, it will be relieved actually. So I hope all of you to finish this journey, and we did this because to share our experience, because really we suffer for this, and all of us actually, all the one who passed this exam, they know what is the challenge on it and the difficulties that say, because it is not just as a matter of reading or matter of, because you have sometimes this exam have a financial issue, have a physical issue, and a lot of things, even psychological issue. So very important to motivate yourself and arrange yourself in a good way, okay, so that to finish this as early as possible, all of you, inshallah. Okay?
Yes,
So
thank you.
yes,
Yes, one question. Well, I haven't found that guideline, the one you just discussed. Maybe I missed that please, can you send me the link to the guideline?
Yeah, of course, I will send it in the all groups. Yeah, this is from the website of the RCOG. So that's why we
Yeah.
always tell that better to not to be alone in this road. Okay, you see what's happening
Yes.
outside you. Really, I choose this because
Yes,
I
thank you
know
very much.
most of people they didn't know this. Okay, and because you
Yes,
are a member,
yes.
so nowadays if you become a member, inshallah, they will send for you any new guideline. Okay, and I
Thank you
hope
very
all of
much.
you, inshallah, you will know all these things, inshallah, and you will bring your dream into reality, inshallah, all of you, to achieve this dream, inshallah. Okay, thank you, all of you.
Okay.
Thank you
Thank
very
you
much.
very much.
Thank you.
Thank you. Very nice. Thank you very much.
Thank you.